Ladies and gentlemen, welcome to this session entitled The Index Valve Matters, Optimal Index TAVI for a Lifetime of Possibilities. I think we've got a fantastic session ahead featuring a live case from St Thomas's Hospital. So thanks very much for coming. We've got an excellent team to help us, a really big team of expertise, and we would encourage you also to ask questions via the app and use the microphones in the room. Before I introduce the team, I'm just going to run through the session objectives. We hope that this session will help you understand key considerations for lifetime management, particularly in low and intermediate risk patients. We want to discuss the impacts of the valve selection for the first intervention on the feasibility of future interventions. We also want to really explore in depth the importance of the implantation technique to achieve an absolutely optimal and durable outcome for the purposes of a long-term result. So I'm going to introduce the team. I'm Phil McCarthy. I work in Southeast London at King's, but we've got an excellent panel of discussants. We have a procedural analyst I'm going to hand over to once I've presented the case, Alpa Ona from Germany. And our discussants are Mariam Akadad, Dave Hildick-Smith, Won Kyun Kim, and Andreas Ruck. And they will help us understand some of the issues, discuss them, answer your questions as we go. These are the ways that you can ask questions and interact. So I hope you enjoy this session and learn as we go. We've got a team waiting for us at St Thomas's with Simon Redwood and Tiffany Patterson, but before we come to them, we also have an excellent patient, and our thanks go to the patient also for taking part in this educational event. So our patient today is a 72-year-old female. She has symptomatic severe aortic stenosis. She's in NYHA class 3 with exertional dyspnea, and she's actually had some exertional presyncope. She has some comorbidity in the form of type 2 diabetes, amongst other things. She's an ex-smoker and has a raised BMI, and that will feature in some of our discussions about procedural technique. She has a BMI of 36. But she's an independent lady and mobilizes unaided. She's on a standard set of heart failure medications, ramipril and eplerenone, amongst other things. And we believe that she is optimally medicated at this stage in her pathway. Blood tests are perhaps not surprising to you in the audience. We have a hemoglobin on the low side, a raised BNP confirming the clinical diagnosis, and fairly reasonable renal function, although a degree of chronic kidney disease with an eGFR of 43. Important aspects of her ECG are that she has a narrow QRS complex, but she has a PR interval that is on the long side. It's within the normal limits, but she has narrow QRS complex, as you see, with a normal axis. And her echo confirms this diagnosis of severe calcific tricuspid aortic stenosis, with a mean gradient of 45, aortic valve area of 0.5, and not much aortic regurgitation. She does have a degree of left ventricular impairment, yet despite an ejection fraction that's depressed, she's still able to generate good gradients, and I always think that's a nice marker of contractile reserve. She has some bulging in the basal septum, which again can feed into some of our discussions about valve sizing. So that's our patient. I'm going to hand over to Alpa now, who's done an in-depth procedural imaging review just to help us understand the issues here. Alpa.
So thank you, Phil, for the brief introduction and the kind words. What are the spots we have to focus on if we measure? So in my opinion, and this is the standard procedure, I think one will say that too, that we have first of all check the annulus. So what we do, we can check the perimeter of the annulus and the area. And the area is here 450 and the perimeter is 76.1, and we don't see really much calcification at that area. So the second area of interest is the STJ and the SOV. And we see also here 23 and 27 millimeters in the STJ, no severe calcification in the STJ, and the SUV is also 29 or 30 millimeters. The third focus is maybe as you said that, because in the echocardiography, I just would say it's a mixed type of aortic stenosis. It's not really a pure type of calcific aortic stenosis. It's a fibrotic type of aortic stenosis. And as you see here, we have some calcium, but not a severe calcification. And I think the measurement of the Gerson score was about 1,500. So the coronary heights are also standardized measurements, and what we see is the right coronary artery and the left coronary artery. Here, the left coronary artery, 12 millimeters, the right coronary artery, 16 millimeters, and the exercise seems to be good. No really severe calcification or tortuous excess vessels. So, said that, I hand over to you.
Thanks, Alper. So I mean, from your summary, it seems that the anatomy is suitable for transfemoral TAVI. This is the kind of standard kind of patient that we see. The summary is shown on either slide. So we have a 72-year-old lady, very severe aortic stenosis, very symptomatic, with some degree of LV impairment. I think the fact she's got LV impairment and she's presyncopal is real markers that she's got critical aortic stenosis with suitable anatomy for transfemoral TAVI. I'm going to start with Andreas Ruck. What are the sort of features? You see this patient now. First of all, surgery or TAVI. The patient has expressed a desire not to have surgery. She has a raised BMI, some degree of renal impairment. Does that fit with the guidelines?
Well, since August, as you know, with the new guidelines, the age limit is 70 between surgery and TAVI, and I think with the overweight and some other factors, it's reasonable to say that TAVI is a good option for her. It's also a good anatomy for TAVI. It's tricuspid, there are no major issues. But what we should think about is she's only 72. She will need to have a functioning aortic valve for maybe 15 to 20 years of her life. So it's quite probable that regardless which TAVI valve we use, we need a second one after that. And also what it's important, she is quite heavy, high body weight, high BSA, means she needs a good opening area of the index valve as well.
So it's really important that we think about the next valve whilst we're thinking about this valve. And we've got to get the technique absolutely perfect, because we're talking about maybe even a 20-year history, which is going to be dependent on how we do this valve. So we've got to get the real detail of the procedure. So, Dave, can I move to you and say, so we think that TAVI is a very reasonable option in this day and age for this patient. I think surgery would carry some risks. In this kind of procedure, if we were going to be using a TAVI valve, would you predilate this? Talk me through your thoughts about predilatation. There's not much calcium there?
Yeah, so I think for this valve, where we're going to be using the Navitor, we will certainly predilate. I mean, one of the things I think with the discussion you've just had there is that I don't want to put too much emphasis personally on the next valve. I know people like to talk about it a lot, but we have to get this valve right. Because actually, even when we look at repeat procedures in the surgical era, it was only ever 5% of cases that actually came to a second procedure.
We mustn't spoil this intervention thinking too hard about that, but it's got to come into the...
Yes, of course, but I think, whereas the guidelines sort of talk about specific age cutoffs, I think that's misguided. We don't want to think 65, 70, 75. We want to think what Andrea said, which is what's her expected longevity.
Yeah.
If it's 15 years... perfectly reasonable to do TAVI. If it's getting to 25 years, maybe it's not such a good idea, But a single TAVI with a chance of, yes, of course, there's a chance you might need a second TAVI, but let's get this one right first. And in this case, yes, we will predilate. I completely agree that this looks, certainly on some of the CT images, as though it's largely fibrous rather than calcific.
As Alper said, it's kind of a mixed thing. There is calcium there. 1500 is a reasonable calcium score, but...
so a sort of one-to-one predilatation, or slightly less because it's not so heavily calcified, may be perfectly reasonable.
Let me go to Won Kyun and ask about predilatation, because this is important to get this right here. We're going to predilate. How do you decide how the size of balloon to predilate, and what would you do here?
Yeah, first of all, I think we have a very different awareness regarding the need of good valve expansion. there has been a paradigm change, I think, and it's going more into the direction of what we do in interventional cardiologists. So I think predilation and assessment of whether postulation is required is very important. Regarding the size of the balloon, I would not be too obsessed with one size. It really depends on the degree of calcification, which in this case is rather mild to moderate. There is severity of aortic stenosis. And for a self-expanding platform, nowadays I'm very generous to predilate. In this case, probably I would do something between 20 and 22 millimeters, not being too aggressive.
Because the lack
I mean, if you are too aggressive, I think the risk of annular rupture is very small if you stay below the average diameter. But of course, the risk of creating AR and having hemodynamic compromise is a little bit increased. But in my experience, there is no big trade-off.
Alpa.
But there's I think to mention, there is a change in the IFUs as well. So I wouldn't treat this patient with a predilatation with a minimum of the annulus, like 20 millimeters. This would not be the right way. We have to be controlled, yes, but we have to be sure that the valve expansion at the end is optimal. And therefore you have to stay in focus with the mean of the perimeter or the diameter, and you can downsize for 1 or 2 millimeters, but not too much.
Do you think if you get the predilatation right, you're less likely to need to post-dilate?
Yes.
Yeah.
Absolutely.
All right, I'm going to come to you now. We've got let's say an intermediate risk patient here. What are the kind of things that you think about? What do you think about when, I know Dave says we've got to get this right, but we are thinking about future interventions. What are the things that you're thinking about in that regard?
Yeah, I think I totally agree. We need to get this one right. We need to get a good expansion to ensure probably a better valve durability, a proper implant depth, reasonably high to decrease the risk of pacemaker.
Pacemaker we don't want.
Because she's pretty young. She has no features of high-risk conduction disorders in her baseline ECG. And of course, we need to anticipate the future. And we have all the tools to do that. We have the CT, so we know the coronary height, we know her aortic root anatomy, and then we need really to get this valve fine, but still think about the future.
I want to talk about the height of the valve, because we're all encouraged to put valves higher and higher to avoid pacemakers, but then when we start to think about revalving in the future, maybe that's not quite so good. Maybe, Alpha, can you address that?
Yeah,
this is the balance. Do we go super high, no pacemaker, but and just explain to the audience what the concern about really, really super high placement is?
Yeah, I think lifetime management is what you have to think about in every valve. So I totally do not disagree with you, but maybe not absolutely agree with you. So we have to think about the second valve in this patient, because her life expectation is maybe 80, maybe 90 years. So we do not know how durable this valve will be. This is not a miracle. It will be durable, but maybe not for 15 years. So we have to think about that. We want them to have low pacemaker rates. So because pacemaker is an issue, it's not a pity, it's an issue. So therefore we have to implant the valve high. At the other side, if you do a valve-in-valve procedure, you have concerns with occlusion of coronary or sequestration of the sinus. You have to take that in count, I would say, and you need the balance. But that means for me that even if you think about that, do not go too deep with that valve to provoke pacemaker dependency.
But also have a look on the CT at the perimembranous septum depth.
So tell us about that. I mean, so that's an interesting...
Well, so if you've got plenty of room, let's say it's 5 or 6 millimeters, then you know you've got a margin of safety, you've got a normal ECG, you can afford to have the valve slightly lower and give yourself that margin of safety when you put it in. I mean, it's already going to be a low risk of pacing anyway, but to know the perimembranous septum depth is actually quite helpful.
Yeah, so it comes down to this really detailed CT planning, doesn't it? And we're going to come back to some of these themes in our talks after the case, because these issues are extremely important. Do you think that the durability of the valve, Mariam, the durability of the valve, is that dependent on how well we put it in? Tell us about that, in terms of how long we're hoping the valve's going to last.
Yeah, I think we have data now showing that under expansion may have an impact on health first, and we know that there's a link between health and SVD.
Yeah.
So I think we have now we have to understand that we need to put this valve properly and pre-dilatation, putting the valve at a reasonable implant depth, not too high, not too low, and assessing for expansion on fluoroscopy when we implant the valve are very crucial to ensure that we have a good immediate result, but also probably a better durability in the future.
Yeah. Do any of you measure the STJ height for the potential for coronary sequestration with a near tube and a near skirt in the future? Mariam, do you do that routinely to look at the height?
We do that routinely.
Because that would go into Dave's detailed CT planning. Look at the perimembranous septum, but you also look at the height of the STJ, because if you feel there's a near skirt that's going to come above it, then that may influence your...
Yeah, exactly. It can influence a bit our implant depth. We're not going to go very deep, but in some borderline cases, we can use this height to say, look, if I put it at 0, for example, then I have a higher chance of sinus sequestration. Then we're going to do that. And on CT, we also do something. We determine a left main view that can help during the implant. It's a eleocranial view, typically. And during the implant, we can have a better sense of the relationship between the left main and the valve.
Brilliant. So I think that we could summarize by saying that we all agree that TAVI is an excellent choice here. A self-expanding valve with a Navitor seems to tick all the boxes here. We're very keen to talk in more detail about the implantation technique. And it's time to go across to our friends and colleagues at St Thomas's, led by Professor Simon Redwood, Dr. Tiffany Patterson. I understand that they are ready to broadcast to us, and I think they've been listening to our deliberations. So Simon, Tiffany, welcome.
Welcome, Phil. Welcome back to Cath Lab 1 at St Thomas's Hospital. So I'm Simon Redwood, and doing this as a first operator is Tiffany Patterson. We've heard some of your discussion, and perhaps we could just go to our strategy. I think it broadly fits with what you've been discussing. And the next slide, please. Next. So we'll show you in a second, but we've already done ultrasound guided access of both left and right femorals. We had actually planned to do a right radial, but the right radial is very small, so we switched to a left femoral as secondary access. She's quite large abdomen, and we were worried about access, so we've actually put in a 20 French gore dry seal, which we can easily pass a Navitor through on the right side, and on the left side we've got a 6 French sheath with a pigtail, which is sitting in the aortic root for secondary access. And we have actually just crossed the valve, which was actually very straightforward to cross, and we've got simultaneous aortic and LV pressures, and perhaps we could just show that very quickly. So our plan is to predilate with a 22 true balloon. We will then deploy a 27 Navitor vision, and then we'll measure hemodynamics, and hemostasis will be single proglidin angioceal on the right side and a single angioceal on the left side. So if we could show the hemodynamics now, please.
We had a quick snapshot of them, didn't we?
There we go. So you'll see there is a peak-to-peak gradient of approximately 40 millimeters of mercury. So this is undoubtedly significant aortic stenosis. And then now what I'd like to do is if we could switch to echo. We've just done an on-table echo, and Karina's going to talk through those images that she's taken.
Thank you, Simon. So I'll just show quickly the key images we acquired at Bushra. With top left image, we see parasternal long axis view of the left ventricle. We see the LV function is a bit better than on previous echo. We see it looks quite like prominent basal septal bulge, and we already see the heavily restricted aortic valve leaflet. And we move on the top right image here. When we zoomed on the aortic valve and put our X-plane orthogonal cursor, we see heavily calcified aortic valve leaflet, very minimal opening in end-phase view. And we gradients through the aorta with the CW signal, maximum 3.7, VT mean gradient 31. This is a bit lower than on previous echo, but we need to bear in mind this patient is under sedation. And aortic valve area clearly in the severe range, 0.6 centimeters square by VTI. And just show bottom right image of the LV function. So overall, probably mildly down. LV, right ventricle is not dilated, has good function, and rest of the valve, at a quick look, there is no significant abnormality here.
Beautiful images.
Thank you, Corinne.
So it's interesting, Simon, the discrepancy between the CT and the echo, because you look at that echo and you think, oh, that valve's quite heavily calcified, bulky, calcified leaflets, and then some of the images on the CT don't look like that. So it's just a reminder that different imaging modalities can give you different feelings for the valve.
We often see that, and it's the window that we take when we're analysing the CT. It often underestimates the extent of the
That's
calcium.
right.
And we just wanted a bit more information.
Does the septal bulge influence your strategy here, Simon and Tiffany? What do you think about
it does generally, but this looks like it sits away from the annulus.
That's right, it does. It's low,
downwards.
isn't it?
So we're hopeful this won't have any impact on deploying the valve.
Now,
But
Simon,
yes, of course
can I
it
just...
does, particularly if we...
Could I press
Sorry,
you
just
on
to
your...
say, it would really worry us if we were going to use a balloon expandable valve.
Yeah, that's right, because it can
because
move.
of the risk of embolization.
Your choice to use a sheath in a sort of sheathless system, it's an interesting point. I think it's something that we all do with slightly more hostile access, be it deep or tortuous or borderline. I mean, I quite like controlling things with a sheath if the access is going to be an issue. Do you often do that? And if so, for what cases do you place a sheath when you're using the Navitor?
So I'll just tell you my take on that. But we don't do it often. We probably do it in about 10 to 20% of cases.
Yeah.
If the iliofemorals are very tortuous, calcified, or stenosed, we prefer not to be crossing the iliofemorals several times, so we just put a sheath in.
Yeah, I agree, Simon. What we don't want to be doing is pushing the valve through the leg in a deep abdomen, trying to squeeze it in when there's a lot of overhang. And also, we don't want to be trying to, again, sort of push through with loads of force in heavily calcified iliofemorals if we can. It's rare because the delivery system is so smooth. But on the odd occasion, if we feel like there's maybe a little bit too much push, it might be sensible to use a sheath in those situations.
Yeah. No, I think that's really well made point.
Is usually, I mean, the ultrasound-guided puncture was very straightforward, and we shouldn't have any problems closing with a single proglide with an angioseal. So that's where we are now. So perhaps we could just show the images that we've taken on angio, if we could change to angio. So this is our three-cusp view. It's a shallow LAO cranial 23.
Yeah.
And next view is our cusp overlap view.
Beautiful.
Which was nice, actually. Wasn't too steep.
That looks like a really nice view there. Your very sharp indicator of where your annulus is. And can you just...
the next...
Sorry, Simon, to interrupt, but can you tell us why that cusp overlap view is important using the Navitor?
It's very important for any self-expanding valve for depth, for initial depth. So where the pigtail sits there, we'll aim on the markers on the Navitor being at about that level, so that the Navitor deploys, the end of the ventricular end of the Navitor is just below that. And then once we've got up to about 70-80% deployment, we'll probably go over to a steep LAO view to check depth and check expansion.
Yeah. So it's a really good marker of the depth of implant.
And then the next thing we've done is we actually have the valve has been prepped, and we make sure the valve is prepped and ready to go before we do our balloon valvuloplasty, just in case we get catastrophic aortic regurgitation. I know it's very rare, but it can happen. And so what we do is we screen the valve to be absolutely certain that it's been loaded correctly. So the next view, that's screening the valve and just turning it around, and you can see it's been beautifully prepped.
Okay.
Excellent.
I was a little bit worried because these valve leaflets are quite stiff, and I thought you probably didn't want to watch me trying to cross the valve for about 10 minutes. So I crossed the valve in advance just to be sure that, as that wasn't the main focus of this session, I crossed the valve in advance just to be in, and also so that we could show you the invasive hemodynamics.
Yeah, so that's the TAVI wire, isn't it, Tiffany, that you're using there?
Actually, no, we haven't got a TAVI wire. We've just got a pigtail.
Okay, fine. Okay.
So, and then in fact, the crossing took about 10 seconds. Not 10
Yeah,
minutes.
typical.
Yeah, it was quick.
It wouldn't have done if you were live. So.
Exactly.
Okay, so we're really excited about this case. We want to sort of explore all of the details of implantation techniques. So we're really interested to know why you're doing things. So we'll let you crack on with the case.
We've got lots of time, so we can do that nice and slowly and answer any questions as we go.
Yeah. Before
So
you
the next
start,
step is we're
Tiffany,
going-
just are there any questions from the panel? Any thoughts? Yes, Andreas Ruck.
Yes, so the question is, I don't think it's anything specific for this patient, but is there anything specific with the wire choice, small, extra small curve, or stiffer wires just for this product? Maybe good for the audience to mention that.
I went for an extra small Safari. We like Safari in general. The pre-shaped curve is quite nice and it holds its pre-shaped curve. I went for extra small because of the left ventricular hypertrophy. Because sometimes the slightly bigger curve can come out of the apex and into the LVOT. Just from my perspective, I feel more comfortable. It sits nicely in the apex and ensures, because we're pacing over the wire, ensures good contact as well.
Excellent. Okay. Over to you.
Happy?
Yeah.
So we're just going to put the Safari in. So we either use a small or an extra small Safari as a routine. And we've got the assist system for injecting contrast.
Let's just go RAO briefly to see the LVA.
Very nice.
Better. That's fine there.
Very nice automated injector, makes life a bit easier. One less thing to worry about.
See more of the apex, please. A little bit more. Thanks, great, thank you.
So I think you can see nicely there in an RAO view, which opens out the LV.
Seems to be sitting nicely, doesn't it?
Looks nicely placed. Thank you.
So we'll take our balloon now. I'll go back to the three-cusp view. I don't know if you have any preference what view you normally do this in. I don't really, either an AP.
No,
pigtails there is
not
a
really.
good
I mean,
marker.
the balloon inflation can give you some information about the anatomy. We've chosen a 22 balloon, Tiffany and Simon. Is that correct? So it was max min, I think,
That's
26 by 20. 22 seemed like a nice compromise. It's not overly calcified, or at least according to the CT. Was that you don't want to over-dilate
usually
it?
it's somewhere between the minimum diameter and the mean diameter,
Yeah.
depending on the extent of the calcification.
I
Would
always
they
spend
style
time
it
thinking about this,
with the
Phil,
same
because I
balloon?
never really know. I want to be as assertive as I can be to make sure the navitor is well expanded, but with the compromise that you don't want to cause too much injury. And you want
that's
the valve
right.
to hold.
Alpa just has a quick question.
Would you, hi everyone. Would you post-dilate with the same balloon if it would be necessary? Or would you change the
Usually
balloon?
that's our practice.
Not.
Yeah, that would be our normal practice. Do you
So
have
you
any
can-
thoughts?
We would initially start with using the same balloon and then see what result we've got, I think.
Recusp?
So you see we've got pacing on the wire, so I've just connected the crocodile clip to the wire, and the other end is connected to the skin at the left femoral.
So this is a true balloon. We're going to pace, rapid pacing. I quite like pacing a little bit faster just to keep the balloon still because I don't like doing multiple inflation, so I'll probably go for a pacing rate of 210 here. And then I quite like to see the balloon grip before we fully inflate it. And I'm trying not to be too ventricular at the risk of causing conduction problems. Okay, pacing on, please. That's not capturing, so we'll stop there. So should we try 150 and then go up? Let me know when you're ready. 150, please. 210. Go gently there. Thank you. And go all in. Lovely. Down. Pacing off, please. That's great, thanks.
You can see it's interesting. It missed one towards the end of the pacing run.
There was one missed beat there, wasn't there?
Should we just play that back? Yeah.
This is the reason.
Sorry, just give me 2 seconds. I'll just get this balloon back.
I don't think so. So that was very elegant, Tiffany, the way that you're trying to avoid the conducting system. There is a feeling that if you do these pre-dilatations too low, we all know from our clinical practice, you can develop conducting system issues.
Yeah, we've seen it, haven't we?
Yeah, and then they sometimes, hopefully they go away. But so that looks like a generous pre-dilatation. It looks certainly well sized. Any comments from discussants? Mariam just has a quick comment.
And just a question regarding the type of the balloon. Do you have a preference in terms of non-compliant and compliant?
Yeah, so we use a non-compliant true balloon, and the nice thing about that is it's very quick to inflate and deflate.
And it feels effective.
Yeah, and I suppose if you use certain balloons, that won't burst, will it? So this bursting is not an issue with this kind of valve, not enough calcium. But one can just have a quick question as well.
Yeah, I think the pre-dil was very effective, but you have seen that there was some capture loss and the balloon jumped up.
Yeah.
So in case of post-dilatation, would you consider a different approach, a different pacing strategy?
Yeah, so that's a really good point, because you wouldn't want that to happen with your valve was in there. Would you do anything about that? Dave's going to come in.
Yeah, I was just going to say you might want to reposition the Safari wire just because it's a little bit upside down.
Yeah.
You could reposition that
see
through the
the
balloon
apex?
if you wanted to.
Yeah. All good points
Yeah.
and things to consider. We'll let you make your procedural decisions there.
Oh, and the other thing to say, you haven't seen it yet, but the hemodynamics recovered immediately, so they're fine.
No, you're right about the wire. There's also a risk balance of fiddling too much and just trying to... It may correct itself. So we've got the Navitor Vision delivery system here.
Got the wire.
I don't know if you can see it. So this is our inline sheath here, and this is the delivery system. Simon's holding the other end, flush ports at 3, and I'm going to introduce it through the gore dry seal here. But normally we would do this without a sheath, as Simon said. So that's gone very smoothly, and I'll just bring the system up. Let's go off mag, we go around the arch. Let's open up the cones.
So Tiffany, one thing about the Navitor is it does navigate the arch very easily, doesn't it? It's quite a flexible, sort of gentle valve, even with very hostile anatomy. You're looking in the LAO projection
I really like
there.
that about it.
Yeah.
Yeah. I do really like that, and I like the fact that actually sometimes I just do sort of a push-pull myself around the arch as I feel it going round, just to make sure it doesn't scrape the outer curve, and that's quite a nice way of doing it as well. So we're just approaching the valve here. We've moved over to ariocaudal for our depth.
So this is your cusp overlap view. Very
Yeah,
nicely
that's right.
shown, yeah.
So you see the pigtail is sitting nicely in the non-coronary cusp.
Yeah, that's a really important point,
base of it.
Simon, isn't it? Sometimes your pigtail moves, and it's always worth a little check to make sure it hasn't moved, because that can be quite confusing.
And the Safari wire position is really good now.
Yeah,
Looks-
as Tiffany said,
Yeah.
it moves on its own.
Corrects
So
itself.
Very nice.
she was right. So that was a good call.
I'm just going to advance the system. Are you happy for me to advance now? We're going to cross the valve.
We could do, yeah. We could see the hemodynamics on the left-hand half of the screen. That might be helpful. There we go. Perfect. Thank you.
So I'm going to unsheath to the valve, and then I'll probably start pacing at that point. I don't know if that's your usual practice as well, but just to get the big sheath out the way and everything back a little bit.
So pacing, you don't need to pace too fast, but it does stabilize the deployment, doesn't it? So pacing at maybe 120, 150 tends to stabilize, but not everyone does it. I think it's a personal preference. So tell us what you're doing, Tiffany. You've lined up your vision markers with the pigtail. You know the pigtail's on the annulus, and there doesn't seem to be much we're going to talk about parallax in a minute, but there doesn't seem to be much parallax with the vision markers, which is nice. So your first step is to just bring the capsule back to the valve itself.
Yeah, to the valve edge. That was my plan. And we do that with the delivery knob. I was going to turn this and essentially unsheath the system. I don't know if you can see the blue.
Yeah, we can see everything now, actually, quite nicely.
So and the other thing to say, so Tiffany's doing this, is it can very much be a single operator procedure, which is nice. It's a very stable deployment.
So you can see the valve's gone in a little bit deeper there. I'll be keen to hear your thoughts. I like to be across the valve fully so that I can control a little bit in the LVOT rather than being too high to start with.
Yep.
And then I sort of reassess from there. I'm not sure what your practice is normally.
Yeah, it's exactly the same, actually. I think that you want to minimize movement of the valve across the native valve. So it tends to come down a little bit as you unsheath it, but not too much.
That looks good there.
Okay.
And we can see that the hemodynamics are nicely stable. The diastolic's down a bit, so you've got a bit of AR there, but not surprising.
Well, when I put some pressure. So when what we'll do is we'll start pacing now. I'll probably go for 140, and then I'll start unsheathing. They're just refilling the assist machine, so we're not going to have dye for a minute. So pacing on, please. Yeah, that's capturing. Pressure's dropped quite a lot there, so I'm just going to unsheath, but bearing in mind we do need the valve to expand. What's my height there? So I'm a little bit deep. I'm just pushing on the wire a little bit.
Yeah, so that's a good procedural tip, is to just push on the wire, stabilize the whole system, bring it across, maybe onto the outer curve a bit.
It's a tiny bit deep.
Yeah. A bit more dye, sorry. Using quite a bit of dye here, apologies.
The kidneys are good though. That's good.
Okay. Dye again.
Pacing is a little bit erratic, isn't it?
Yeah, it is. I think that's because I'm pushing on the wire. It might be me. I don't think I can blame anyone else. Okay, so that's starting to expand there. I think we may have some. It's a little bit deep actually already on the spike.
Yeah, so there's a little bit of parallax,
Why don't we just
isn't
release it and see? Yeah. So I've gone all the way to that sort of hard stop. The valve's opening. We can go off pacing there. And why don't we go to the? Let's wait for the pressure to recover, and we can go to the LAO
Take
view.
a picture or not?
Pressure is doing.
I just want to.
So the pressure is coming up.
All right.
And there's parallax between the valve
Straight
and the
LAO,
native
please.
anatomy, isn't there?
No cranial.
So it's really important
A little bit more.
to appreciate
More
that now.
That's good.
There.
That's a lovely view.
Should we take a picture there? So what do we think about that LCC?
So
A little bit
that's
low on there.
Low, yeah.
so this is interesting. So maybe Andreas can comment about that position. So we have a nice height on the cusp overlap there, but on the left side it's a little low. So what do you think of that position,
And a bit of leak.
Andreas?
Personally, I mean, you can be really picky and say, okay, we want it like 3 millimeters higher, but I'm not really sure I would care so much about that. And I also feel the anatomy dictates how it will sit in the end with the angulation to the aorta. So it might change a few millimeters when we release. I would actually be happy with this.
You'd be happy with that, Dave? Do you agree?
Yeah, I think so. I think you have to be slightly wary in this case that there isn't that much calcium.
Yeah.
So, maybe you think, okay, I'll accept a millimeter lower than perhaps otherwise I would.
Yeah.
And the other thing to bear in mind is that septal bulge. So if anything, it'll move up, not down.
I've got to say, I'm a little bit aware that there's a paravalve leak around that.
Around that left side?
Left side,
Yeah.
yeah. I'm just considering perhaps a tiny recapture, because
coming up maybe
just
1 or 2
subtly
millimeters.
and see if it'll come up. The problem is that when you start recapturing, you can create more issues for yourself. That's the other thing to weigh up here. But
it's always much easier to say how to do things than actually to do things in the cath lab. I mean, what you want the valve to move anti-clockwise here, and that's easier said than done. People talk about overlaying the whole system, pushing on the wire, and pushing the system so that you hug the outer curve and move the valve anti-clockwise. But like you say, Tiffany, there are issues with capturing and recapturing, and better is the enemy of good, as they say.
But if you are thinking of recapturing, maybe I would come to RAO caudal and just have a look, and we'll see there that perhaps it is just a little bit low.
well, we can definitely take a picture.
So
of
we
an
could
RAO
take a
caudal.
cusp
Let's
overlap.
definitely
That's a good idea.
But I think because my main concern is a bit more RAO, a little bit more RAO. My main concern is the left side. I would probably, if I was recapturing, I'd probably do it in LAO so I can watch what's happening there. That'd be the main reason, because I think we were good on this side, and it's quite hard to understand.
I suppose you could push on the system. I mean, you know, on that cusp overlap, it's perhaps a millimetre deep, but, you know, it's a bit too deep on the other side, perhaps.
Let's go back to the LAO that we have.
So that's interesting.
And the other thing is you can see the hemodynamics are very stable, so you know we have time to discuss this. And
Yeah, exactly. The diastolic's a little bit low, so I suspect the AR is important. So tell us what you're going to do, Tiffany.
So I think I'm just going to recapture.
Partial recapture.
The issue with recapturing, partial recapture. What I don't want it to is to jump out into the aorta, so I'm just going to keep an eye on that, to be honest.
just recapture enough to move it up.
And pushing the
It's a
wire
sort of
and the
a
system
balance.
to bring it across. Might be nice.
I think I will.
Yeah.
I'll see if it moves a little bit on its own. Can we open up the cones, please, so I can see everything? I'm going to first see if it moves a little bit on its own. Then I'm going to see what we need to do. You're right, pushing on the wire is better than pulling, but I think it's going to be I'm just going to go by how it behaves,
Yeah.
to be completely honest. So I need you to open up the cones, please, because I need to see everything. Thanks, that's great. And is this max fluoro, yeah? So we'll probably start pacing again. I'm just going to start slowly. I'm going to recapture a little bit first, and then we'll pace. I'm going to go in the other direction. Can I have some dye, please?
Start doing a bit of push on
Yeah,
that.
just push a little bit on the wire, but we also need dye at the same time. Yeah. It's okay. We need to just inject. Thanks.
Pacing.
Pacing on, please. Yeah. I need you to do dye for me. I need dye. Inject more. I need you to inject. Thanks. Inject.
Put over then. Yeah, so you're pushing on the system there, I can see.
So that's moved up.
It's moved up a bit, yep.
Bit there.
So we've got no pressure. I'm just going to
Release.
Boy, there.
so we've got to open the valve up, apologies, and then we can reassess what we've done there without causing too many problems. Pacing off.
That looks like it's moved up nicely.
Looks very nice.
Okay.
I mean,
Yeah, it
you've
does.
got a couple of millimeters that you've gained there. Really nice.
And it seemed
We're just
it's
waiting for our
just
contrast
the pressure to
refill,
recover.
apologies.
Yes. So it seemed that you were pushing both on the system and the wire there, Tiffany, which pushed a whole lot across onto the outer curve and really improved, I think, the angle
Yeah.
of deployment. So
I was losing height on the NCC, which I didn't really want to do. So that's when I then countered it with forward pressure on the system. Should we do a picture there, see how that looks? Doesn't look much better, does it, actually?
Oh no, I think
it does.
If you compare this to the previous one, it's moved up.
Should we go back?
And if we deploy with some positive pressure on the wire, it should.
Let's go back and see the other.
Previous picture.
I'd be wary not to recapture too
Back
many
one.
times.
yeah. So
back
Wenkan
again.
has a comment just from the
Yeah, well,
discussants.
I think it doesn't look too bad, actually. And I think we have to take into account that the contrast dye, when the valve is more open, doesn't
RAO,
indicate
please. Straight
nadir.
RAO.
And I think it looked better when the valve was not fully open.
Yeah.
so the contrast doesn't go into the natil completely. So I think there is a slight improvement, and it's also acceptable.
It will move up a little bit when it. I mean, they do tend to move up a tiny bit when they're deployed. So I wouldn't be going much higher than that. As Dave said, there's not that much calcium there.
Phil, may I one comment?
Yeah.
I wouldn't do decisions without a second projection. Always.
Yeah. Well, we have two there. This is the RAO caudal.
Yeah, so I've thanks for that. It's a good point. I just went to RAO to check expansion, and it might be worth us just showing you that. And then I came back to recheck the vision marker on the NCC.
Hemodynamics look good
one.
now. It's a bundle branch, unfortunately.
Yeah, it's left bundle. I must say I'm happy. I think this looks good.
Yeah, so I think we'll probably, I'm going to have to pull back on the wire a little bit when we do the final deployment, and just, I think I'll hold down the system, just a gentle bit of pressure on the system. That might, I'm hoping that will right the LCC a tiny bit more, but it may have an effect on the NCC as well. I don't know what you do with final
well, I think
deployment.
two of your three vision markers there, you've got a nice view without parallax. Two of them are absolutely spot on the annulus. The one at the left side is a little low, but I think that you're going to have great difficulty getting that up. I think if you do get that up to the annulus, your other markers are going to be too high. So, and there's not that much calcium here, and the valve will move up a little bit when you fully deploy it. So I think that I would be looking to deploy that now and release that. Mariam?
I agree, just to say that. I think the position is pretty good, and the risk if you try to go higher on the left is that you lose position on the non-coronary cusp, and then
you
get
a little
too
bit
high.
of some firm support, not forward pressure, but some firm support as you release so that it doesn't move up anymore.
Okay, so I'll pace on the final release, 140, and we'll do that now. Pacing on, please. I just want to make sure we've got some good capture.
That's good.
Can I have some dye, please? And then I'll pull the pigtail back, I think.
A little bit of gentle pressure on the device.
Yeah, just holding it. That's gone a little bit deeper on the LCC, but we've also, the parallax has changed. Okay, pacing off. Okay, let's see if we can correct that. Should we come less LAO?
No, so in terms of the deployment, we need to make sure that all the tabs are released,
Less LAO.
which you have done there. Valve is
I think we
stable.
can see 3 there. Okay.
Yep,
So
we
I
can.
think we're probably we're going to have to bring the system back. We'll keep the wire in.
Hemodynamics are good.
Yeah, unfortunately, I don't think we can always predict which way it moves.
No, the native anatomy will dictate the final position, and there's only so much you can do
Just feed the
in
wire.
terms of deploying.
Great.
So you're just recapturing the nose cone now, I think, and
Yeah, we've
Preparing.
recaptured the nose cone and we just removed the system.
so
I think we'll do a quick picture.
And we'll show you some hemodynamics.
I just want to make sure there's no parallax there. Let's have a look. Our imaging isn't
Oh, it's
great. Maybe, okay, let's take a picture here. Yeah, we've got a tiny bit of leak on the, it's gone, looks like it's a little bit deeper than we initially anticipated. Let's go to RAO
I'm not so
caudal,
sure.
please.
I think the vision mark. I can't see on this screen, but I think the vision markers on in the middle and on the left look pretty good. Maybe a little bit deep on the left side.
Shall I put a pig in here for our next picture?
So How do you normally assess the valve once it's in, Tiffany? Do you do aortograms? Do you do a transthoracic echo? What's your routine practice?
Yeah, so we tend to do an aortogram. Sometimes we do invasive hemodynamics if we think it's going to change what we do. A lot of the time, we don't tend to fiddle with the valve too much, to be honest. If we've got a nice position, it looks well expanded as this one does. Unless there's an issue, we don't tend to do too much. We just tend to do an aortogram to assess the AR. I know lots of people sometimes do some fancy things, but really we go with those as our main indicators.
So we're going to take an aortogram.
Okay.
So you can
Let's
see
open up the cones.
simultaneous pressures there. There's no systolic gradient.
So it looks like the valve's probably well expanded.
Yeah.
Okay.
So there's no gradient at all, isn't there? It looks nice.
I think there's a bit of a whiff of AR.
That's not the view that you had, though, is it? Because there's parallax with the...
No, this is the RAO.
I was just checking
that's
the height
alright.
here,
Okay.
and the vision marker looks like it's still on the NCC, so I'm happy with that in terms of conduction and following up afterwards. And then let's just go to LAO 1520. You can see the valve is nicely expanded.
Yeah, it's very good.
We don't need the cranial, actually.
So do you want to take the pigtail out?
Yes, there, stay there.
Do a
Yeah.
picture.
We can always cross again if we need to. Just want to assess this properly. No, I think actually
looks okay.
it's not looking too bad.
Yeah, I think that looks okay.
There's no,
I think,
can't see any obvious AR.
I think you're bang on the
Expanded.
annulus with two of them, and you're perhaps 1 millimeter, 2 millimeters below. I think it looks quite nice. I don't think there's
I mean, it was
any
a safe
problem with that.
deployment.
I guess
a bit of
the issue now
refactoring.
is assessment for post-dilatation. You've got a very well expanded device. It's at a good height. You've got a nice dichrotic notch on your pressure traces. You already have left bundle. I guess one of the issues is if aggressive post-dilatation to get rid of a tiny amount of PVL will risk a pacemaker. What would you do, Andreas, here? Would you do a transthoracic echo? Would you use the AR index for invasive hemodynamics?
I mean, I think to distinguish between trace and mile, I think the AR index is not sensitive enough for that, so I wouldn't do that. We would do an echo, but I would be very surprised if I would see much of a paravalvular leak here. It looks pretty good. So on the frame expansion, I think it's quite typical that in the REO view, it looks much smaller than in the LAO view. That's just because the annulus is not round. It was, I think, 20 by 26 in this patient, so probably not unexpected. So I would be quite happy with this.
I think it's conformed to the native anatomy really well, Tiffany. I think that it looks like it's fully expanded, sitting on that septal bulge that Simon quite rightly said is sort of slightly lower down, so it's given you a shelf to sit on. Hasn't really influenced your deployment. It's very secure in the ascending aorta there, well expanded. I think that's an extremely nice result. This is live, is it?
This is live echo, yeah.
There's a tiny paravalvular leak, I think.
We're just doing an X-plane just
Okay,
to look
one
at the
thing, did you want
valve
to make
expansion
comments?
starting at the top. And we're just walking our way down, and you can see that in the orthogonal right view that it looks like that the valve is nice and circular. We're coming to the leaflet tips now, and the valve is opening and closing well. Maybe a very slight oval shape to it, but it looks pretty good, well expanded in that aortic root, and then into the LVOT. And we're just going to pop some color on that now as well, just to have a look at that. So we'll just zoom on that picture just to make sure that there's nothing major going on. And it looks really nice. So we've got fairly laminar flow through the valve itself as well. Maybe a slight edge just at the top here. Can you see there's a slight paravalvular leak?
Very small.
Just coming in at the top here on the right. So I'm just going to move down towards it there. So it looks like there's a mild leak. We can look at it in more detail, but it's not worrying us too much. And the valve expansion looks good. The leaflets are moving well.
Do you think there's any room for the valve expanding a little bit further over the next 24, 48 hours, Phil? Or what do you see?
I mean,
Do you see
what
those
it's done is
parabolic
it's conformed to
curves?
the native anatomy. If you look at the slide, we have the slide of the annulus beside, which is quite an oval annulus, and I think the valve's quite nicely just conformed. You have a little rim of sort of trace to mild PVL. I don't know, Wonkin, what would you do?
No, there is no reason to do any additional measure. There's a good expansion. We have no gradient. There's trace leak, and given the capture loss that we had during the predilation, this would increase the threshold to do post-dilatation.
Yeah, so
absolutely no reason.
The jeopardy of post-dilatation would be that it misses a beat on the pacing and you move the valve up higher. Or indeed, I mean, there's a little bit of conducting system alteration there. It would be a shame to convert that to complete heart block, wouldn't it? Mariam?
I think I agree. It's, for me, it's trace PVL. I wouldn't do anything now. And you still can reassess the patient in a month or so. And if you feel that the PVL is worse than you thought, you can get a CT and book her for post-dilatation just to improve valve expansion if needed.
Maybe one additional comment. The implantation depth is not so bad. It looks deep. But again, there is no opacification of the sinuses because the sinuses are very narrow. So the implantation depth is not that deep.
No. So I think the feeling from the panel here, Tiffany, is that it's an extremely good result, and we probably wouldn't be wanting to post-dilate just for the sake of what seems to be sort of trace PVL. And as you say, as the valve warms up and expands in the next 24 hours, sometimes we have seen these leaks go away completely. Would anyone post-dilate this? No one would wish to post-dilate this. Alpa, no?
No.
So no one on the panel would post-dilate. Tiffany, what about you and Simon? What do you think?
No.
We feel
Happy?
the same.
Very happy.
Yeah, I think so, yeah.
Great.
So shall we...
I think that's a very good result.
Phil, I would say
Thank
it's
you.
the best result for the second valve.
Yeah.
Yeah, because we talked about that.
Yeah.
We can, to be honest, it seems a bit deep, maybe, but because we talked and discussed it before, for lifetime management, maybe if we consider a second valve, this would be an optimal position.
Yeah,
for a
because
second
we
valve.
don't have a pacemaker, unlikely to need a pacemaker, and near skirt is kept as low as possible. Great. Well, I think that was a very elegant demonstration in quite a tricky case. So well done to the team in St Thomas's. Thank you very much. I mean, it's much easier sitting here and saying put the valve here there than actually doing it. And I think that was quite a tricky deployment, but a very, very nice result. So excellent. We've got some time to debrief. We'll leave you to look after the patient and just have a debrief on some of the issues that have arisen from that. Did you have any final comments you wanted to mention now?
No, I think we're happy. We've assessed everything. We're going to stop here, close the groins. Nothing further from our side.
Brilliant.
Thank
you
you.
again. Thanks very much.
Thank you.
So we're going to just talk about some of these issues, and by all means ask questions if you want to, because they'll be coming through to Alpa, who can field them. Let's talk about some of the issues that arose. I'm interested in the angulation of the valve. So Andreas, you have a valve which is spot on the annulus on one side and too low on the other. What did Tiffany do? What do you do to get that coaxiality?
Yes, I mean, typically it's what you can do is push-pull on the delivery system, and then of course work with the wire. And I noticed she held the wire very elegantly to the delivery system, so you can then control it. And with this system, it's easy to control deployment. With one hand, you don't need two people to do it, and then you can actually control the wire at the same time.
Yeah.
So that's what you need to do.
So you're trying to push the whole thing over to move towards the outer curve, to move your device anti-clockwise.
Yeah, so the more the outer curve, the higher it comes on the left side. Yeah.
Yeah, easier said than done, but that's the technique. And just assessing before we release the valve. So I'd like to just now, we think we've got a nice result. It's still attached to the delivery system. We still can recapture it. Alpa, what are your steps that you go through to assess that it's safe to release the valve? What do you do to make sure that it's not going to do anything unpredictable?
I will ensure that you have not much energy in the valve and in the
Yeah.
system.
Yeah.
You have to release all this energy out of the system. Carefully deployment, very slow deployment, means it's stable on the
Yeah.
point where you want to have this valve. It is, you can really precisely implant the Navitor Vision valve. As an implanter, I think I did more than 500. I can say, okay, there are some issues, but this is not an issue for this valve because you have stable hemodynamics and the stable position.
Yeah.
What I do not prefer is to work too much with the wire and the system in push-pull. Not
Yeah.
too much.
Yeah.
Because you do not necessarily need.
Yeah.
The valve seeks its position. And therefore, be careful and do it in a very slow fashion, in a very slow way, and it will stay continuously on that place with fast pacing and a very, very slow release.
Dave, you...
Can I ask a question about that pacing at the end with the release? Because, I mean, not that I'm an experienced user of this valve yet, but what I routinely will do is take all the tension out. So I'm pulling the Safari back and neutralizing all the energy
your
in the
pacing will be
system.
less reliable.
So you won't.
Yeah.
Your pacing won't work. Why do we need that pacing?
I think pacing is a personal preference, and the speed at which you pace. I sometimes pace. I don't pace as fast as Tiffany personally. I pace at 100, 120, really just to remove the ectopy. Because if you're getting a lot of ectopy, it's bouncing around a bit. But I tend to just suppress the ectopy with 100, 120. But I think it's a personal preference, and I think, like you say, I don't think there's strong guidance. What happens, Kim, if you've seen your valve and there's clustering of the cells? Tell me about clustering of the cells before you release. What does that mean? What do we?
Yeah, you really need to look at the expansion, and that could indicate infolding. And in this case, I would do be very generous with resheathing, because every time you resheath and unsheath, this is like a valvuloplasty.
Yeah.
So, and you will see, if you are not satisfied with the first expansion, you see clustering, etc., infolding, then I would be very generous with resheathing, do it once or twice.
So you come down to areocaudal to see that. It's a good idea also to be generous with your views, isn't it?
Of course, if you have several
don't do everything
views,
in the same view.
you're on the safer
Move the
side.
camera, move it around. Get rid of parallax, have a very low threshold. You often see clustering if you come down back to your cusp overlap view, don't you? You think it looks okay in the LAO view, and you come down to areocaudal, you think, hang on a minute, tell me about, if you leave that and ignore that, that means there's a bit of energy in the device, and a pop-up or a brisk movement on deployment is more likely. So when you see that, you do a partial recapture. Is that your strategy?
Yeah, partial recapture, and look at the implantation depth, whether, you would like to have some safety margin, right? If you are not really happy with the opening in the inflow and or with the expansion. And I think it's really important to look at this prior to release.
Yeah, so there's a couple of mental checks about before you release. You look for clustering of the cells. If there is clustering in the areocaudal, you partially recapture to help expand it. There's no energy in the device. Dave?
But I think Andreas's point is really good, because you can't expect in areocaudal the same degree of opening of the valve.
No.
It will always look a tiny bit more constrained because it's elliptical.
Yeah.
So don't let that fool you necessarily.
No, you just got to make sure there's not this crowding of cells, which might be a marker of the valve doing something unreliable when you release it. The other thing is, once you have released, what are your checks? So you've released, you think got a nice result. You don't want to grab defeat from the jaws of victory. How do you make sure you don't dislodge the valve? Just talk the audience through your mental steps as to
I think
tabs that release.
Yeah, I think the release is one part of the implantation, but it doesn't end with the release. It ends with the safe retrieval of the delivery system. You have to make sure that there is full disengagement of the delivery system.
Again,
from the
move
tabs.
the camera, move the
Exactly
camera.
what we have seen, and we have seen that all three tabs were released. And after making sure there's full release, then you can retrieve the valve. I think it is helpful to centralize the wire, so there is no interaction with any valve structure.
Yeah.
and to be very careful also in this stage. And I would include also the retrieval of the pigtail.
Yeah.
Question is, some operators pull the pigtail without wire. I never do it.
Yeah.
Because once in a while, you could pull out the whole system just with a pigtail.
Yeah.
So it ends with getting everything out of the valve.
Really good tips. Alpa.
Phil, what I meant earlier was, you see here the system. Let me just check if I can point it out with a pen. Yeah. Okay. You see the system. Can you run the move? During the release, you have a slight kinking here in the inner side of the curve. And what I meant with too much push and pull to the system and to the wire means that you come to the outer curve maybe in a form of a kinking, but there is energy in the valve, in the system. That means if the energy is released while you release or deploy the valve, that means the energy has to go somewhere. And sometimes it goes deeper on the left side and higher on the right side. And this is the spot where I stop the deployment and think about what I'm doing again.
You're right. Think about the energy. You don't want energy in the system.
We do not want energy in the system. This type of energy deeper is not that bad, maybe, for this position. But sometimes, if you start very high and you have this type of energy, it can happen that the energy releases in the upper side.
Yeah.
So you lose the valve out of the annulus.
Yeah.
And this is something you have to be careful of. If you have this sign, like a kinking and the movement in your system, you see there's energy in your system and in your valve.
And I think it's worth just quickly revisiting parallax, because we saw Tiffany with the vision markers quite nicely lined up when it was in its capsule, and then as soon as the valve starts to deploy in the native anatomy, you get parallax. Just tell the audience about the importance of appreciating that parallax. What are we talking about when we talk about parallax?
So, the annulus is in a native form not really plane. It is not in a three-dimensional way. It is not in a two-dimensional way. It is in a three-dimensional way. So the valve seeks its own place in the annulus. So we define the annulus at this point, but there is no anatomical point where we can say, okay, this is the annulus and this is not the annulus. The valve will seek its position, but what you always can do is you can double check your position with that valve, because due to the factor that it is an interannular working valve, you have time, you do not lose control, and you do not lose the pressure. Therefore, in my opinion, they decided, and it is not impolite meant by me to say, okay, I would do it in another way because I do not have the tactile feedback the operator has. But in these cases, I would recapture fully than just partially, because then I have again the fully control of the system.
Yeah.
Because once you have the touchdown fully in the LVOT, so your concerns are gone because you already had one and you can start from the beginning.
Yeah. One can.
I have one question to the audience, to the panel. If you have a situation like this, it looks a little bit deepish. The default recommendation upon release is to be neutral, right? No push or pull on the delivery system, release the wire, and then deploy. In such situations where it looks a little bit on the deeper side, would anybody exert a slight pull on the system? Would be very interesting.
No.
What do you do?
No, I wouldn't. I mean, one thing I do is you look at the ascending aorta and the position of the device in the ascending aorta, and you can predict whether the valve is going to move clockwise, because if it's at an angle, you can see it's going to expand on the outer wall of the ascending aorta and will therefore move clockwise. So you can slightly predict which side's going to go down. What you can't predict is which side's anchored and which side's going to move. But you can predict whether the valve will move clockwise. So I would say that when you're in that position, I certainly wouldn't advocate pulling it, but I would be looking at the trajectory of the delivery system. Are you on the inner or the outer curve? And try and predict which way the valve is going to behave when it expands.
Phil, there are 4 questions from the...
Okay, let's go through those, and then we've got two mini talks. So we've got a couple of minutes.
Okay, the third one is maybe interesting. Can we make a prediction as to feasibility of TAVI and TAV with this valve in patients?
Well, so Mariam can tell us that, because just about to talk about it.
Yeah, I think definitely first on the angio, you see that so you can count the nodes on the valve, and it depends on which position you're going to implant a second valve. But we know that we can safely implant an S3, for example, a short frame valve in a tall frame valve. Let's say we aim the outflow of the S3 being at node 2. Definitely in this situation, we see that it is below the STJ. So in this case, I think TAV in TAV will be definitely feasible.
So the other comment is the one at the top saying the nose cone, the management of the nose cone. Dave's already alluded to sort of pulling the Safari back, centralizing the system, making sure your nose cone doesn't catch your valve and pull it up, which of course it theoretically can do. And then there's a system for recapturing. It shouldn't damage the aorta because it's actually on the stiff wire. It's pretty safe to bring it around and recapture it. So I think some of these, there's some questions about commissural alignment. Of course, with all of the valves we have at the moment, commissural alignment has got challenges. There is a way to align the commissures, and that is important. But I think with all currently used devices, commissural alignment does remain a bit challenging. But I completely agree. It feeds into this discussion about revalving, and we'll touch on that with our talk. So if you don't mind, because of time, we're going to move to our first talk, which is from Won Kyun. And we're going to talk about hemodynamic considerations in patients with small annuli. This patient didn't have that small annulus, but also the impact on small annulus, TAVI, and durability. So Won Kyun.
Yeah, thanks Phil for the introduction. I'm talking about hemodynamics, and I think it's important if we think about valve selection, especially in patients with small annulus. We saw a compelling live case. By definition, it was not a small annulus, but it was a female patient with a smallish annulus. And I think let's go. I will provide a short overview of what we know about hemodynamics in these patients. And there's some literature. Due to time constraints, I will not go into detail. There is some randomized data, also observational data. And I would summarize that in self-expanding valves used in small annules, we consistently, across all studies, we see, of course, lower gradients. There's less PPM. There's higher device success, which is, of course, related to the gradients, which is a component of the definition. But we see no impact on early mortality up to 1 year. But I think it's quite clear that there's a difference, small self-expanding versus balloon expandable devices. Also, you could discriminate intra versus supraannular valves. Regarding the impact of PPM on mortality and a bioprosthetic valve failure, it is not as clear as with surgical aortic valve replacement. We know that after SAVR, there's a relationship between mismatch and outcome. Regarding TAVR, it is more or less controversial. And I have shown you here two meta-analyses. One meta-analysis showing that only in patients with severe PPM, there is some signal of higher mortality after 1 year. It's a work of from 2019. More recent analysis, 2023, suggests that there is also impact of mortality, of PPM on mortality after a time frame of 5 years. But this is highly controversial. Probably because we treat a different patient population. Patients are older, probably less active, and so you cannot directly compare it to the surgical patient population. Regarding impact on durability, also, it's not crystal clear, but here is work suggesting that PPM is associated with a higher incidence of bioprosthetic valve failure. So in the end, I would say there is no clear association, but my personal take is if I can avoid PPM, especially severe PPM, I would try to avoid it. So if you look at different valve designs in hemodynamics, we were talking about intra versus supraannular. Here also we have balloon expandable versus self-expanding devices. And you see that the design and the opening frame of different valves can contribute to hemodynamics. And I have asked myself, with the Navitor that has been used in this case as an intraannular valve, why should it have a hemodynamics that is comparable to supraannular valves? And if you look at how the valve opens, I'm not an engineer, but you can see that the opening area is relatively wide due to this cylindrical valve frame. And you can see it in the data that I show you with the Portico. This is a pooled analysis. The Portico was the very first generation, but we have 5-year data, and you see sustainable hemodynamics over 5 years and PVL rates that are acceptable for a first-generation device. And also with the Navitor device, you see very good outcomes at 30-day and 1 year sustainable hemodynamics up to 12 months and a very low rate of PVL. Thank you very much.
Thank you very much. So the data does seem to suggest that hemodynamics, and I think it makes sense, doesn't it? Hemodynamics are going to give you a better long-term result. If you've got bad hemodynamics, your valve's going to wear out. We've seen it with the surgical valves as well. Any comments, Dave, about that? How much do you think the Navitor certainly seems to give extremely good hemodynamics considering it's intraannular?
Yes. I mean, like Kim, I must say I was slightly skeptical when I sort of initially saw these results, and I thought, well, how can this be the case when it's an intraannular valve?
Yeah.
Surely we would get better from the supraannular. But as you elegantly expressed, there are perfectly good reasons about the design of the valve that mean that this is entirely plausible. And of course, the 5-year data are pretty impressive, even albeit that it was the previous generation. So I think, I've had to reconsider my stance on that and my assumptions that intraannular wouldn't be as good.
Yep, interesting. Okay, well, I think in view of time, we're going to move directly on to our second talk from Mariam Akudad. And this is really important in terms of our discussions with this particular case, 72-year-old lady. Mariam's going to talk to us about future interventions, revalving, and coronary access. Mariam.
Thank you. So I think the most important thing we need to understand when we talk about revalving or TAV in TAV is that the neoskirt is the most important concept. So when you're going to put a second valve inside an index valve, then you're going to push open the degenerated leaflet, and it's going to create a kind of covered stent that will not allow any flow or any catheter to go through. And of course, we want this neoskirt to be as low as possible to allow for coronary access, but also to avoid having coronary obstruction during TAV in TAV and depending on patient anatomy. So the neoskirt will vary according to valve size and design. Usually you have a higher neoskirt with tall frame valves, but there are other factors that needs to be considered. One of the most important factors can be anticipated during the index procedure, and this is the implant depth. And you can see with this CT simulation analysis that if your index valve is implanted a bit lower, then your neoskirt will be shorter and you'll have more chance to be able to do a redo TAVI in this patient. Other considerations are the second valve type and implant strategy. If you choose a tall in tall strategy, then you're going to have the maximal neoskirt. But if you choose a short frame valve to implant in the index valve, then you can tailor this neoskirt and get it shorter if you'd like to. And this is nicely shown. If you have a low implant of a SAPIEN 3, for example, in the Navitor, then you'll be able to do a redo TAVR in almost 100% of cases. So coronary access is a bit a different story. Of course, it will depend on the neoskirt height, but not only. So this is just an example of another CT simulation study, and you see that a Of course, if you have a low implant of a sapien in a Navitor, then you'll be able to get coronary access in all patients. But if you have a higher implant, then coronary access will be unfeasible in almost 20% of cases. So other factors that will play a role apart the neoskirt for coronary access are commissural alignment. This is not possible with all platforms, and it can be challenging sometimes. And you see, for example, in this video here, that if you have commissural misalignment, it can be tricky to get a proper coronary access, especially if you have a closed cell frame. Another factor that you can absolutely not predict is what we call cell strut misalignment. When you put your second valve, it's going to end up in a certain position. And then if you have cell misalignment between the two frames, you can have a very narrow hole and that not be able to access the coronaries, even if the first or the second valve are commissurally aligned. So this is another very interesting study where they assessed for coronary access following TAVI implant. And you see that if you have a short frame valve, of course, you have a better coronary access, but you still have differences among the tall frame valves. And you see that if you have large cells, open struts, then you have a better chance to get a coronary access than if you have a closed cell design. Other factors, of course, are misalignment and implant depth of the first valve. So this is not something that we have available on routine. So this is a specific patient CT simulation, but we can use these technologies in complex cases where we simulate the first valve that we want to implant, and then we simulate the second valve. And you see in these two examples that a high implant of a sapien in this Navitor in the left of the screen will lead to have a sinus sequestration with a high risk of coronary obstruction. As opposed, if you implant a bit lower, then you can see that the coronary ostia are above the predicted neoskirt, and then you're happy with this and you can proceed with the TAVI aiming this position. So to summarize, we know that redo TAVI procedure are expected to grow because we are treating younger patients. We need absolutely to optimize the index procedure to get better hemodynamics, long-term durability, to avoid any issue in the short-term time. But we always need to think about the future and plan the future accordingly. And we can do that, and we need to do that before the index TAVI procedure. And of course, it's going to be a tailored approach according to patient-specific anatomy. Thank you.
Thank you. Excellent points. Mariam, can you foresee a day in the future where we routinely assess the next? I'm mindful of Dave's comments about not getting too bogged down with the next procedure, but do you think that as part of it, because CT analysis is just getting more and more sophisticated, and measuring the membranous septum and 3D reconstructions. Can you see a day when we do that routinely, where we say, okay, this is our plan, and we've thought ahead and do the next?
Yeah, and I think it's already coming in our routine. If we have patients below 75, now we really do in-depth CT analysis to simulate the first valve and then simulate the neoskirt that we're going to get and think about the options that we have. Yeah, we just definitely do it.
Questions from the audience? How are we doing?
Not a question, but there is a comment. Interannular is the way for a first TAVI. Supraannular is unnatural and will always be an issue with coronaries.
Is that the chief executive of Abbott?
I think that it's really important for people to understand about coronary occlusion, because the mechanism of coronary occlusion with the first valve is slightly different to the mechanism of coronary threat with TAV and TAV, isn't it? And you mentioned the neoskirt. What we're talking about with the first time is usually an occlusion with a calcified bulky leaflet coming across the ostium being pushed across the ostium of the native coronary. But with TAV and TAV, it's all about coronary sequestration, isn't it? Just emphasize that point, Mariam, because it's a really important one.
Yeah, I think it's a bit of both, but you're absolutely right. There's a risk of direct coronary occlusion if you don't have enough space and the coronaries are very low. But most of the time, what we see is that this is a risk of sinus sequestration because the neoskirt goes up to the STJ. And if the STJ is narrowed, then you have a chance of sinus sequestration, which will lead to unfeasible coronary access, but also coronary occlusion. And for the supraannular versus intraannular, I don't think there's a simple answer to that. And I think the most important point is to know your patient anatomy. And the most tricky situation is small anatomies, because everything is complex.
Yeah. But I mean, if you think 10 years on, our patient today, 72, they're going to be 82, maybe the kidneys have deteriorated a bit more. If we find there is a very high risk of coronary sequestration, then you know we have a problem, don't we, retreating that patient, because if they're not fit for surgery now, they're certainly not going to be fit for surgery in 10 years. So you know there is a fear that if we get this wrong, we create a very big problem for ourselves down the line in a patient who may not have many options.
Yeah, so that's why you really need to anticipate this. In this patient that we treated today,
yeah.
We knew on the CT analysis that there was no risk of sinus sequestration.
Yeah.
So
Yeah.
STJ was wide, high, so there was no risk. But of course, if you anticipate this risk, you really need to put all the options on the table and pick the best one.
Yeah.
So maybe one comment on that, or maybe you have one comment on that. So is it much more important that you don't have a misalignment with the stent cells of your TAVI valve than the misalignment with the commissural?
I think it's an excellent question. I think commissural alignment is really important if you have a closed cell design, even more. I mean, it's an important point. If you can have commissural alignment, it's always better. But it's even more important if you have a closed cell frame. And I think that cell misalignment is a big issue, because you can absolutely not predict that. And if you have two large cells that you gonna overlap, then you still have a hole big enough to access the coronaries. It's more about coronary access than risk of acute coronary obstruction.
Thank you.
And in young patients, they've got a long time ahead of them to develop coronary disease.
Yeah.
so 1 or 2% incidence of acute coronary syndrome in this population. People are going to need to access the coronaries in the middle of the night, maybe. So these are really important features. Any more comments from the...
So sometimes I would say, if they are old enough, I would say, but maybe we can look in the future. It's not about diagnostic coronaries, because CT scan is okay for
right.
that. But sometimes you can treat patients like, if they are very old, NSTEMI patients, it's not always recommended to do directly coronary angiography.
No, exactly.
We have time.
Yeah.
One question, do you think that in valves with large cell frames, commissural misalignment is more forgiving?
I think so for coronary access, but there are other issues with commissural alignment. We know that maybe the flow cannot be optimal if you don't have commissural alignment. You may have a higher chance of underexpansion, higher chance of halt. So we have to take all of this into consideration, and I think that the future, and I think all the companies are working on that, is to have good commissural alignment and to allow for redo TAVI, coronary access, etc.
Any further comments from the audience?
No further comments.
We've had good interaction. So it's down to me to close the session, sum up our key learnings. I'd like to start by thanking the team at St Thomas's for what I thought was a really elegant demonstration. Quite tricky anatomy, but lots of tips and tricks. I always learn a lot when I see people doing these things, and it's very different actually doing these procedures than talking about them where we are. It's easy to talk about them on the panel. But I'd also like to thank my panelists for really drilling down on the implantation techniques. For me, the take-home messages here were that you've got to have meticulous attention to detail with implantation technique. You need to get the height right, the angulation right. You need to predict. Most problems are predictable. And we need to get this perfect, not only because we always want it to be perfect, but particularly when we've got a patient that may have 10 or 15 or more years of life ahead of them. So it's attention to detail with the implantation technique, and I think an awareness in the low and intermediate risk group that what we do now in this procedure may create problems in the future. So I'd like to thank everyone for taking part, the discussants for a lively discussion, and thank everyone in the audience for attending. I hope you learned something. Thank you.